OCT. There's a little bit of OCTA, but not so much on the OCTA this time. I was asked to talk about OCT and retinal vein occlusions. And as before, there's some Optos images and mostly Heidelberg images. So one of the issues, of course, is what is the diagnosis? This is actually a patient I just was referred not long ago at all by one of my colleagues who said there's an 84-year-old patient, their vision's down, 624. They previously had a central retinal vein occlusion in the right eye and just no useful vision in the right. And they said they've got a pigment epithelial detachment and they've got a branch retinal vein occlusion, which would imply they've got macular degeneration and a vein occlusion. So the question is that true? What is this image telling us? There's certainly interretinal fluid and there's this space here. Is that really a pigment epithelial detachment, or indeed is that just part of bad macular edema? There's another cross-section further up and you can see it looks like edema, and there's the topographical map showing quite significant edema. And one of the features, of course, of vein occlusions is that they tend to present more dramatically with very significant swelling compared to, and it can look very similar to diabetics, except it happens much quicker usually, and you often get worse amounts of fluid. So this feature, and you will see it as I show various other cases, this is not AMD, this isn't really a PED, this is just a feature of having quite a large amount of macular edema. So as the macula swells, this layer will lift up too. And so it doesn't mean they've got AMD at all. There's no drusen, there's nothing else wrong with this deeper layer here. So vein occlusions is very much an interretinal fluid thing, but you do get some subretinal fluid. And the same is true in diabetics. Most of the fluid is interretinal, but you can get subretinal fluid. But what you don't get are thickening and drusen type deposits or just thickened material at this level. It's all interretinal, well, and the subretinal, but it's fluid. There's no actual problem. As you can follow along here, this all looks normal. So this is a vascular problem. But it's basically a leaky problem. There's a lot of fluid. And as we've been saying before, fluid, inject it, basically, unless it's not in the very center, in which case maybe you laser it. But this is central fluid, and it's quite a dramatic amount of fluid, so this patient needs an injection. And indeed, to show that this wasn't really AMD, they've had one eyelid injection, and I saw them again just a couple of weeks ago, and they've improved quite dramatically so far. That swelling, that supposed PED is almost gone as the fluid settling down. Possibly there's a slight epiretinal membrane here as well, so the vision isn't come up perfectly. And what about this, though? So often people are older, and vein occlusions, just like almost everything else, is more common as you get older. Same with diabetes. So often there will be dual pathology. So this patient does have a problem at the level of the RPE, and they've got a lot of interretinal fluid. So is that a vein occlusion, or is that AMD? Or is it both? Does it matter? We're still going to inject them. They've got fluid in the middle. There's a lot of fluid there. Probably does matter from the prognosis point of view. They've got some material here, so they may well not do as well. But you don't forget looking in the eye of the patient. This patient does have drusen, but they've also got a branch retinal vein occlusion. They've got hemorrhages spreading out here. This is not AMD hemorrhage. This is a vein occlusion hemorrhage that's going all the way to the periphery. So this patient has a branch retinal vein occlusion and AMD. But the leak is due to a vascular problem. You can see it's all interretinal. You can get interretinal fluid with AMD with RAP lesions that Theo mentioned before, but nearly always they will have thickening and changes at the RPE level as well. So what happens when we start injecting these patients? What are the OCT changes over time? You're probably all very familiar, but I'm going to show you just a case just to show what happens with fluid and how do we try and manage this. A 72-year-old person with a lady with a right central retinal vein occlusion. As I said, they often come in with quite a lot of fluid, all these big spaces. Essentially, this is cystoid macular edema, this pattern. That is what gives you the petaloid pattern if you did a fluorescein, these big spaces. Interretinal fluid, you can see there is that very slight bit of subretinal fluid, very common with edema. So this is 2015, August. So we injected them, come back, actually there's still fluid, so we keep injecting them. November, it's gone. But that isn't the end, is it? We know that is not the end. So January, it's back. And when the fluid comes back, quite often in a vein occlusion, it will come back quite dramatically. I think diabetics is a more chronic, slower change of fluid. Veins often swing up and down quite violently, so they do get that lifted up area again and the intraretinal fluid. So we inject them again, it goes away, comes back, goes away. There's possibly a little bit of a defect here. We're holding off. We're doing PRN as our regime of injections. We're not treating till fluid comes back. So one of the questions is that a good plan? So this is June 2017. July, oh, I think I've got the date wrong. This is 17. Fluids come back again. More, and you can see it on the infrared, the shadow of where all the fluid is. And that subretinal fluid again. Treat them again. So it was 16 anyway. We've now gone a year, and we're still injecting. November, there's a little defect here, so that may compromise the vision slightly. But January, then we switch to Eylea. What do? We keep injecting. More fluid again. Goes down. But then we begin to think, well, this, it's not good for the eye to keep fluctuating up and down this wildly. So then you consider, well, should we be treating extending rather than just waiting till the fluid comes back? Because particularly in vein occlusions, it does come back quite dramatically. So once we've proven that we haven't cured it, so what I tend to do is give them a few injections, goes dry, then I'll probably wait. In some people, you'll be lucky, and it's not going to come back. But an awful lot of them, it will come back. And if it is going to be the sort of person who's going to come back, well, I'll be considering treating extending and try and keep them stable, at least for a much longer period of time, and then maybe try stopping again. So this is May 17, July 17, September, and where we're keeping injecting now. But they have remained stable. We've now gone into this year, and now we're back up just to a couple of weeks ago. So they're not getting that many injections, about once every 3 months, but we haven't had that wild fluctuation of fluid. What's happened with the vision over all that time? Well, this is our graph from our Medisoft data. You can see the vision going up and down. It's beginning to drift down slowly now, and you can see where the injections have happened. So we've actually not really been given any more injections than we were when we did the PRN bit. Probably maybe giving actually slightly less, but we haven't had the wild fluctuation of fluid, so it is much more stable. This patient has had 5 years' worth of injections, and that is the nature of vein occlusions in many people. You just don't seem to get quite to an end. What's happening now is they're beginning to get a little bit of cataract, which is an old lady, and we're injecting her all the time. It's quite common to get some cataract. So the decision often, the initial decision is it a vein occlusion? But basically, is there intraretinal fluid? Is there fluid you're going to treat? How are you going to treat it? Mostly it's injections, unless it really isn't involving the center, and when you might still consider some grid laser for a BRVO. But then how do you monitor it? So as I've shown you that one, we were looking at really quite dramatic shifts of fluid. This one is slightly less certain, and I was looking at the map. Can we use the map to tell us what's going on? You can see at the beginning there is some cystic fluid on that little cross-section, and that's where the branch retinal vein occlusion is causing the thickening. This lady is a younger patient, only 47, so I did inject them. And the fluid comes down quite a lot. The map improves. You can see before and after, and the cystic fluid's gone. And indeed it continues to improve. We do our 3 injections. Then we decided to observe. You can see the beginning and now is slightly different, but not a lot. But it is beginning to go a bit redder, but there's no change in the actual cross-section. I can't see any fluid. And then the most recent visit, which is only a couple of weeks ago, this had definitely got worse, but I look at the cross-section and I can't see any cystic fluid. So it is beginning to swell, but it hasn't actually developed specific cysts. And the vision's very good. So I have to say I'm not sure what the right answer to this is. In other words, you can see thickening without specific localized cystic spaces. Just the whole retina is beginning to become maybe more spongy and beginning to thicken up, which we see more clearly on the map than we do on the cross-section. And it looks like this is just going to recur. So we could just hold our nerve and do nothing and wait and see it gets a bit worse, or we could inject them. And I did actually decide to inject. She herself has said, well, in the last few days, I begin to notice my vision's not as good. So this is the graph of the vision, and it's been pretty stable despite that. But the fluid is changing. So I thought that was quite an interesting example of if you just look at the cross-section, we're very used to looking for big cystic spaces in vein occlusion. Maybe we miss things if we don't look at the map as well. Changing gear, what's going on here? You can see this vision's awful, and there's very hyperfluorescent inner retina, and then you get a much darker area than normal here because this is all swollen, so you're getting a bit of masking. The map is showing it is swollen, quite dramatically so. So this is a central retinal artery occlusion. An artery occlusion doesn't cause you big cystic spaces, but it does cause this very white appearance where the inner retina's edematous, it's infarcted, so the effect of ischemia on the nerve fiber layer will give you this white effect. A bit like, I don't know if in the cotton wool spot I showed you in the diabetic, you get a sort of an opaque looking patch that it does cause some thickening. So it is swollen, but it is due to ischemia of the nerve fiber, or death of the nerve fibers in this case, because their vision's hand movements. And in fact, 2 months later, that's what it looks like. You've completely lost the inner retina. It's very thin, which explains why they haven't really got any useful vision, and they're not going to get any useful vision recovery. If we look on the map, it's all gone blue this time. You don't often see the blue on the map. You're normally seeing green or yellow, which is normal, and red and white if it's really swollen. But actually, if it's thin, it'll go blue on the Heidelberg system. So the whole retina is thin, in keeping with that being thin. If we look at the actual eye, of course, it does. You can tell the vessels, they are there, but they're thin. The whole color is wrong on the multicolor. And this is you get different channels if you're not familiar with the multicolor. So you get green, blue, blue reflectance. That's what these are, and that's the mixture together. And the whole thing looks a bit grainy. If you compare it to the other eye, much more healthy looking multicolor, and all the layers look much more healthy. So what's happening in this patient? This is half of it's gone swollen. Anybody know what this is? Any suggestions? Yeah, so you've had a central retinal vein artery occlusion. Remember, this scan goes that way, so you always look where the little arrow is. The scan goes that way. So this bit is here in the dark. That white area is actually the healthy retina, which is this part, so that's normal. The rest of it is all infarcted. So this is a central retinal artery occlusion with ciliary retinal arteries sparing. So that half is normal, this half is not. So it's quite a dramatic illustration of that. And sometimes you get two things going on. So this patient's got a white and a red, and this is swollen, but this is blue, which is thin. So how do we explain that? If we look at our cross-section, interretinal fluid, and that's the line slightly up here. So this looks like a vein occlusion. This is all interretinal fluid. This isn't AMD. This is a vascular occlusion. But the lower part of the retina is really thin. So that looks like that central retinal artery I showed you. So actually, they've had a branch retinal vein occlusion and previously a branch retinal artery occlusion. So some people just have all the bad luck. They're a vascular path, and when we look at the actual color, there's various pathology going on here. There's some cottonwool spots, bit of hemorrhage, and the artery is missing in this lower part. So they've actually had a branch retinal artery occlusion, and now they're getting a vein occlusion. So we're going to treat the vein occlusion bit of this, but we can't restore the lower part because the retina's gone. So by looking at the different levels in the map, we can get a better idea of the overall health of this tissue. And interestingly, if you look really carefully, this is an example on the Topcon Maestro camera, which I thought was quite interesting, just a cottonwool spot, because this patient came in complaining, and then sometimes you get somebody complains of a little shadow near their vision, and it's really hard to explain why. This particular patient came in complaining of a little shadow in their left eye, and if you look, there's a cottonwool spot here, and the scans here are just below that cottonwool spot, so they're normal. If we go into the cottonwool spot, you can see that same white appearance that you saw with the branch retinal artery and the central retinal artery occlusion. That is essentially the same thing, but it's just on a very small scale because it's a cottonwool spot rather than a whole branch of an artery blocked. But it does give you the same thing, this opaque, bright signal in the inner retina. But the interesting thing is that this is now, and then this is 3 months later, 3 months later, the cotton wool spot's gone. There's nothing to see clinically. The patient still complains of a little scotoma in their vision. So if I hadn't seen this patient at the beginning and they came in because they'd waited 3 months for their appointment, they would have been complaining that they couldn't see properly from that left eye. I'd have looked in the eye and said it's normal. If I look really closely, and I have to say this, I probably would not have noticed it, but if you do, that OCT is not normal. It's thin where that cotton wool spot was. So the damage from the cotton wool spot is still there, which I think is quite interesting. So how you pick that up if you didn't see the cotton wool spot in the first place, I'm not sure. But people who get cotton wool spots do have permanent damage, which you can detect on an OCT and might, in rare occasions, explain why they have some visual scotoma. So I thought that was quite an interesting example. Another aspect of vein occlusions, of course, is ischemia. So this is a wide field of a branch retinal vein occlusion that really is very ischemic. You can see there's almost no circulation in that quadrant here, and there's a bit of new vessels. This is an early stage of the fluorescein. So as we run through, they do begin to reperfuse a bit, and you can see it leaks. And the vessels in the ischemic area are all leaky. They have this sort of fan-shaped effect. So this patient's got new vessels in the ischemic branch area, probably need to be considering laser in that area. We can image this type of new vessel with our OCT-A. Whether it changes anything, I'm less certain, but this is that new vessel complex on the OCT-A, and I can see that it is draped in front of the retina just there. So it's not a high risk of bleeding, this one, I would say, but we're going to have the vitreoretinal talk next so that she may be able to tell me. But this one is not spiking up into the vitreous and a high risk of bleeding. It's just draped flat across here. And there is an argument, if you go back to the original branch retinal vein occlusion studies, the CVOS and the BVOS studies, do you laser a new vessel elsewhere prophylactically? And actually the outcome of that study was you don't. You wait till it bleeds or causes a trouble before you laser them, because the risk of it doing you much harm is very small. I think they are quite old studies and their endpoints were blindness, so we tend to probably do intervene earlier than that. So I think I would treat this patient because they definitely are quite ischemic. But it's interesting just to consider that the trial data does suggest you don't need to. And maybe the reason we didn't need to is because this hasn't got traction and it may not really be very likely to bleed, but not at the moment. Another aspect of vein occlusions is this business of ischemic vein occlusions is what treatment do we do for them? Previously you had a ischemic central retinal vein occlusion. We lasered it because we didn't want to get rubeosis. And then it was said, well, maybe you don't need to laser them. You should wait until they get rubeosis. So you follow them really closely, and it's only if they begin to get it, then you intervene with your laser, because only about 50% of people with a truly ischemic central retinal vein occlusion will get rubeosis. So you're going to be lasering some people unnecessarily and lose some of their peripheral field that they might have recovered. But the danger, of course, with that is that you don't follow them up closely, you miss it, and they get the rubeotic glaucoma. So there's still maybe we should just get on and laser them. But then, of course, we've got anti-VEGF now. So if you get a bit of rubeosis, well, you can inject them, and that will get rid of it temporarily. Or maybe, how do you know that they're not going to respond to the anti-VEGF anyway? Should we just treat them even if their vision's rubbish? Because there is no vision cutoff in our practice. Our NICE guidance says, macular edema for central retinal vein, you can treat them. Doesn't matter what the vision is. So should we just treat them? Is that going to work? So I'm going to try and address some of those issues. And also, how do we really assess whether the retina is ischemic? There's a lot of criteria there to decide, is it ischemic or isn't it? And so some of the questions I wanted to ask is, well, can we predict which one is not actually going to respond? How can we properly assess whether it is ischemic? And if you do treat it, well, does that mean it is no longer an ischemic central retinal vein occlusion? If you give them enough anti-VEGF, does the circulation recover so that they're no longer ischemic and therefore not going to get rubeosis several years down the line? So I'll see if we can address some of those. So if you clinically, you could say, to diagnose somebody from the CVOS study, basically, if they had more than 10 disc diameters of ischemia on a fluorescein, that was one of the criteria. Of course, this was not wide field fluorescein, this was 7-field color. If they had a poor vision, so less than 660, if they had a relative afferent pupil defect, if there was lots of hemorrhages, if there was multiple cotton spots, All these factors, you could say, well, that was an ischemic central retinal vein occlusion. In the old days, it was clear-cut. That was like that, laser them. But as I say, it's not quite as straightforward anymore. What about anti-VEGF in an ischemic CRVO? Well, actually, it's quite good. In the Cruise study, they excluded people who they thought were ischemic based on an afferent pupil defect. But in the Copernicus, Galileo, the aflibercept studies, they did include people who had poor vision, and the vision could be down to 696, which is quite a bit worse than 660. And it did seem to work. We did a small study using Ozurdex with people with really quite poor vision, and the majority of them did improve, at least for a period of time. They didn't get brilliant vision, but they, it depends how you report vision, but they did get improvement, up to 20 letters improvement. What about neovascularization? If you start your anti-VEGF, do they get neovascularization? Well, in the studies where they were getting repeat injections, it was very rare to actually get any neovascularization. But there was only one patient, and they didn't get the neovascularization until nearly a year later. So have we really just delayed the process of them getting a rubiosis, or have we genuinely stopped it happening? Well, this is a 50-year-old man, so on the younger scale, count fingers vision, so that would certainly count as ischemic. Lots of cotomal spots, as you can see on this Topcon. This is a Topcon Maestro one. A lot of cotomal spots, particularly around the disc. What do we do with that? Well, he had quite a lot of edema, so I gave him an anti-VEGF injection. And actually, a week later, it's significantly improving. 4 weeks, almost back to normal. 8 weeks. 3 months, 6/6 vision. 3 years, 5 anti-VEGF, 6/6. And he's not had a treatment for another 3 years. So it's... I could have written him off as count fingers, cotomal spots, but we didn't treat him. Initially, he's a bit unusual. He's a young patient, and it was very centralized. But what about this patient? 76, glaucoma, count fingers, pretty widespread deep hemorrhages, horrible-looking OCT. This looks bad. It is bad. He's not going to get great vision. But will he get any vision? He did. We started treatment on almost no letters, so count fingers, 48 letters, and 51 letters. And the OCTs comes back to not normal, but the fluid's gone. There is some disturbance here, so the RP is not healthy, and you will see that in central retinal veins and in branch where the RP gets a bit damaged. The photoreceptors, the external limiting membrane where the photoreceptors are meant to be, are damaged. This is an ischemic eye. But from count fingers to 624 or something, it's not too bad. So that gets difficult. Does that mean any CRVO, however bad, we should just treat them? What about this patient? Another one, 76-year-old, count fingers, a lot of hemorrhages, really looks bad. We've done a lot of fluid, but we refracted them, so despite that appearance, they did get up to 45 letters, so they're not quite so bad, but still pretty awful. We've done the fluorescein, and it really is very ischemic. If you look, there's very little circulation going out anywhere beyond there, and what's left is not very good. But they got 2 years' worth of anti-VEGF. So then the question is, well, have we actually improved the perfusion of this eye? I haven't got a fluorescein, but if you look closely at that color image, I think you'd have to say we haven't. There's hardly any vessels there. You can see a little bit of vessel here, but basically there's all white vessels. There's almost no circulation in most of this retina. So it really is still ischemic, despite this patient's had pretty much monthly injections for 2 years. However, their vision is 76 letters. They've had no rubiosis or new vessels. They've had 14 injections. They still get fluid coming and going, a little bit of fluid. So we've carried on injecting, and we haven't lasered them. But I definitely think they're at risk of new vessels if I stopped injecting them. So that's going to be the concern, because the retinal perfusion has not recovered. So I think one of the issues in trying to decide, is it an ischemic eye, and what are you going to be lasering or not lasering, is, well, what do you mean by ischemia? Is it whole retina, and also the risk for rubiosis? Is it the whole retina ischemic, or is it just macular ischemia? Because a lot of how we measure the ischemia is actually what the vision is. The visual acuity only depends on the central fovea working. So if your vision is bad, it doesn't mean the whole retina is ischemic. It could mean the macula is ischemic, or it could just mean the macula is swollen. Once you've got rid of the fluid, then you'll have a better idea if the macula is ischemic or not, but you still don't know if the whole retina is ischemic. If the whole retina is ischemic, well, then they are at risk of rubeosis, and you do need to be considering whether to laser or not laser, depending on how you follow them up. So, and I think the ischemia does not go away with these injections. At least this is an example, but we've got other examples. It doesn't seem to go away. It doesn't necessarily get any worse, but it doesn't go away. So I think this patient will definitely need to keep being monitoring, and so then that gets to be how reliable are they turning up, etc. This is an example of a patient, central retinal vein occlusion. They've had 2 years' worth of anti-VEGF. Their vision has come up, but it's 55 letters, so around 618. It's not great. Their perfusion is much better. They've got vessels. They still have a little hemorrhage in the periphery, so the whole thing's not gone away. As I said, it never seems to go away. We've done an OCTA in this case, and they really do have quite an enlarged foveolar vascular zone, but they've also got a very thin retina. So this patient has an ischemic macula, which explains why their vision is not as good as you might hope, despite the fact they've got no macular edema. But do they have an ischemic eye? Are they at risk of rubeosis, or are they just, can we just use this to explain why their vision's not very good? So we did a fluorescein, and the fluorescein does confirm, as the question I had before about what do you see on the fluorescein when there's macular ischemia? Well, you do see the enlarged FAS on the fluorescein as well. But the fluorescein is very useful to assess the whole circulation. How bad is it? And you can see it's not so bad, actually. There is a little bit of peripheral dropout here, but mostly it's fairly well perfused. So this patient doesn't look to be at risk of getting rubeosis. They have macular ischemia, which explains why they can't see properly, but I'm not going to laser this patient. I'll follow them up if the fluid comes back. So I think there is a role for doing fluoresceins at some point with these patients, or at least carefully considering why is the vision as it is. Is it macular ischemia? Is it whole retina ischemia? If it's whole retina ischemia, do you or don't you need to do laser? I think the jury's still out on that, but there is a risk. That same patient, I was looking back to say, well, were they ischemic at baseline? This issue, did we recover the circulation by giving them injections? This was the baseline image, so there were a lot of hemorrhages, Cottonmore spots. Does look fairly ischemic. But the fluorescein is not as bad at all as the first one. It is perfused, albeit leaky. And that is what a fluorescein will look like with an acute central retinal vein occlusion. All the vessels are feathery. So they're leaking, which is what you'd expect, but they haven't gone. So they're not infarcted, but they're just leaky. So it isn't that ischemic. So it never was that ischemic. We've got rid of the leak, but it wasn't an ischemic eye in the first place, but it did have an ischemic macula in the first place, and that's remained. So I think the issue is this business of correlating your vision with macular ischemia, peripheral ischemia, and maybe there's a role for ultra-wide field fluorescein, or at least color, or just looking in the eye very carefully. What is the circulation like to decide about additional treatment? Just briefly on the OCTA, again, I've talked about it in more detail on the diabetics. How well does that correlate in vein occlusions with visual acuity? Well, not very well, really. This is a study done of looking at the size of the foveolar vascular zone and visual acuity, and you can see it's pretty wide range. So there is a trend, but in an individual patient, it's pretty hard to correlate it unless it's really badly affected. We've looked at our own data to see how many people who we've been giving anti-VEGF for central retinal vein occlusions actually ended up with PRP or indeed got rubeosis. So we had 326 patients, 16 of whom did in the end have PRP. 4 of those after 10 or more injections, 7 after 4 to 9, 5 after 3. So these were all people who were given 3 injections and then we followed up. So it looks like the rate of PRP once you start injections is really quite low, and the majority of them are later on in the line. We are on the whole, treating almost everybody now, so you're starting with people really ischemic. So there's going to be some of these people where you give them 3, the vision's still rubbish, you're not sure you're going to follow them up that well, decide that there is peripheral ischemia, so we would PRP them. But there doesn't seem to be that many. But what happened? So who were those people who ended up with the longer follow-up? What happened? Well, this is the graph showing when we injected them, what happened to the vision. Basically, what happened is we were doing lots of injections, but the vision never really recovered that well and became a bit worse. Patients getting a bit fed up. We're less convinced it's still worth injecting them, so we stopped treatment. But when we stopped, a few months later, they get rubeosis. So my point is, I think the anti-VEGF is potentially just postponing the rubeosis rather than absolutely preventing it. So if you have got somebody who's ischemic and you start the injections and then you decide to stop, it may be at the time you decide you're going to stop, you need to reassess and say, is this at risk? Do the fluorescein maybe, or make a decision. Does it look like this patient's at risk of rubeosis? Should I laser them rather than just leaving them and wait until it happens? I don't know the true answer to that, but that's my impression. We've delayed what happened in this patient, and when we left them and followed up, it came back. And we've got another one, similar scenario, where we did a load of injections. The vision never really got very good, so we stopped. And then it wasn't until another year or so, in fact, that the rubeosis developed. So it does certainly delay it. Another one where we tried, and not everybody, don't get me wrong, not everybody you inject will do well. So with these people had 3 injections and they never recovered. So maybe better just to laser them rather than carry on. Another example. So can we predict who won't respond? I think it's difficult. Can we assess ischemia? Yes, but I think all these models, the OCT, OCTA wide field helps. Not many will actually need laser. I don't think we change whether it's ischemic or not ischemic with our injections, but we may end up unmasking the problem when we stop. So, thank you very much.
Thank you very much, James. In the interest of time, we're going to leave the questions for the end of the session. So